well. So let's talk about some newer concepts with implantology and trying to optimize aesthetics with the concept of body shifting implants and changing shapes so that we can maximize what each component of the implant can give us in regards to stability and aesthetics. A lot of the concepts I'll talk about is in a book that we published, Dennis Centorno and I and Guido and Rick had published on this topic of the single tooth implant. And I'm mostly going to focus on single teeth. And I know that Costa and Petros will talk more about the more advanced type of cases and the applications of these designs with more of the bigger cases, which I've actually gone to their office in Greece and Dubai, and I'm pretty impressed and amazed of what they can do in regards to their same day concept. So you're in for a big treat to hear them as well. A lot of things with implants have really shifted from survival more toward aesthetics, and aesthetics is really the key. A lot of implant systems that really don't integrate or survive or really won't make it in the marketplace. And so a lot has shifted from the original survival studies done in the 80s with Brandemark to where we are today with aesthetics. In the aesthetic zone, however, is that the margin of error is quite small, and if you make a slight little mistake, the penalty is very high. Here's an example of a patient, Nadine. She had come into my office to see Dennis and myself, and you can clearly see the aesthetic problems associated with this implant. And if you look on the right, you can see that there's really no buccal plate associated with that implant, as well as loss of the papilla. And these are really the two key elements in regards to problems associated with implants, is that you usually lose the buccal plate, or the risk is not having the buccal plate and losing the interdental papilla, which are really the two keys associated with aesthetic problems associated with implants. So let's talk about aesthetic implant complications. And I'd like to really focus on 3 points. One would be socket perforation in the anterior sockets. The second would be the dimension of the labial bone plate, and the third would be the interdental papilla. These are the 3 key factors associated with aesthetic complications. And of course, the title of the presentation is talking about the body shift INVERTA implant and how that can help us by changing macro shapes to enhance aesthetic outcomes. Let's talk about socket perforation, and that seems to be a problem that now with CBCTs, I think it becomes even more apparent because now we have the technology that we can actually evaluate things. This was a paper done on quite a few implants, over 1,000, with David Cochran's group in JADA in 2015, 5 years ago. And what they did is they looked at the risk of apical perforation if you use straight or uniaxial implants, and trying to have more of a cingulum approach to the placement of the implant so you can do a screw retain restoration. Hence, you bring sort of the apical part of the implant closer to the buccal plate at the apex, and hence the risk of apical perforation, it was staggering. What they reported was it was about 82%, and that number is extremely high. Obviously now with guided surgery, you can try to plan better, but the reality is that the anatomy will dictate what we really need to do. And hence we're trying to use maybe a design that is not so favorable in the aesthetic zone. In all fairness to the surgeons, I don't place implants. I know Petros doesn't, but Costa does. In all fairness to the implants, I think there's certain risk factors associated with extraction sockets. One would be the pre-existing root anatomy, which is forward, and you may have a tiny fenestration, and as the implant is placed, it may actually walk into that little hole, and hence you'll perforate the buccal plate. The other would be that you have pre-existing periapical pathology that already has an apical fenestration due to the lesion, and hence, again, when the implant's being placed, it can walk into the hole. And the reality is placing implants in the aesthetic zone is not so easy. It really takes a lot of discipline and skill. And you may say, well, what's the big deal? Well, here's a patient that we had treated in 2013, but here she looks 6 years afterwards at a 6 years recall. And you'll notice that she's starting to have some discoloration associated with that implant, that right central incisor. And you can clearly see that there's problems associated with that. Apically, she had sort of this area that you would point with her finger, and you could see here the redness in the mucosa. So some surgeons have said, well, what's the big deal if I perforate the buccal plate? So is it an issue? And if you really look at your cases long-term, I'm not talking about 1 year, but beyond 1 year, 2 years, 3 years, 6 years, 10 years recall, you'll start to see some of these problems come, unfortunately, to fruition. At the time, we didn't have the single cone beam CBCT, so we took a scan. Of course, there's no buccal plate. And this is what it actually looks like clinically. When you perforate the buccal plate, you will then have potential necrosis because you've compromised the blood supply to the remaining buccal plate, and hence this was remediated through grafting. And the reality behind all of this is that this comes at your expense, because if you're treating patients and it's one of your cases that comes back after recall, it's really on your dime. And you have to really start to look at not just short-term outcomes, because everybody can have success short-term, but really having something that's more sustainable over time. And I think that's really the key. And you have to equate the cost, risk, benefit ratio associated with these cases. And it's really humbling to do follow-up on our patients. Obviously, the reality is that Scott Gantz's original work he published in 2008 about the triangle bone, Joe Kahn, Alfred Lau, and Howie Gluckman now have shown that, well, really, where is the bone? It's usually palatal to the root about 80% of the time. So hence, using straight implants sometimes won't take advantage of this triangle of bone that Scott talked about years ago. And hence, you're running the risk of also potentially perforating the buccal plate. There are some solutions associated with this. You can do cement retained, which is something that I do, but not certainly my first choice, because it's just a matter of maintenance and convenience, and Petros would talk more about that. You can use these ASC abutments, angle screw channel solutions, or you can use coaxial or biaxial implants in regards to having something that's screw retained, and Petros will talk much more in depth about this. Now, in regards to this, my number one would really try to be using biaxial implants, because you're changing the angulation at the implant level, not the abutment level. The second choice for me would be doing cement retained. Again, it's not my favorite, because then I have to manage the cement and removal. Using customized abutments clearly improve that. And Irina Sala wrote a great paper about contour of cement retained abutments or cemented, restorations, and what the abutment design should look like. But the third would really be the angle screw channel solutions. I know this is sort of a hot topic, but they have some problems. Number one is that the tie base tends to be very short to accommodate the angle correction. Obviously, the more angle correction you require, the shorter it needs to be, or it'll come through the buccal aspect of the crown. It's limited right now to all ceramic restorations, and there's limitations to how much torque that you can deliver at an off axis. And Chandra Wadnati has published this in JPD recently, and he said that the threshold of being able to deliver 25 Newton centimeters of force is about 15 degrees, which would roughly be the incisal edge position. So Petros will talk much more about the coaxial implant and the concept behind that. Now, another benefit with using a coaxial or angle correction implant is that it has something called a variable platform switch, which means that the buccal aspect tends to have a greater platform than the palatal aspect. It's just because of the angle correction of the head of the implant. And what happens is that it means that because the implant is providing this change in shape and bringing the prosthetic interface more toward the palate, that means that you have more gap distance to actually graft. And Barry Levin, who has done a lot of these implants, really loves it, because he says he has the ability to place more graft material, whether it's bone graft and or connective tissue grafting and or his dermal apron technique. And hence you end up with thicker tissue. And I don't know of any surgeon who wouldn't want to have greater tissue thickness. In fact, we've actually looked at this and measured this with Hanai Saito and Barry and Dennis myself. And we actually found that as we looked at the data that Hanai had published on platform switching by itself using straight implants will enhance peri-implant soft tissue thickness, but using the variable platform switched or coaxis implant will enhance that even further just by macro implant design alone, by anywhere from say 0.5 to 1 millimeter. So that's clearly an advantage. So we now understand that changes in macro design can enhance aesthetic outcomes. And I think that's really important. And when speaking to Barry about this, the conclusion was the following, that if we have thicker tissue, that means that we can have increased resistance to midfacial recession, which is a key element. So understanding that changes in design can enhance this. Well, what about the labial bone plate? That's always been sort of an interesting topic, a hot topic over the last decade or so. And what I did is I brought in papers that look at tissue discoloration. Shigemi Nagai at Harvard, Bennick and Hammerly in Switzerland, and we also published some information about this. And the bottom line is that if you looked retrospectively at implants, or even prospectively, which we're doing now, but these retrospective studies have shown that there was anywhere from 20 to 100% tissue discoloration associated with implants. And that, to me, is a very high number. Park and the guy at Harvard showed 100%. Bennick showed 60%. We showed 20%. And it also could be a factor of implant design. And the reason why you would have tissue discoloration, obviously, is that you've lost the labial bone plate. What are some of the facts associated with the labial bone plate is the following, is that it tends to be extremely thin. This is well documented in the literature. I don't care which study you've looked at or what methodology they've measured it. So it tends to be thin. It's about 1 millimeter or less about 90% of the time. Implants do not alter the wound healing or remodeling process of the labial plate. I think that's a huge contribution from Arujah and Lindy 15 years ago. Implant position and diameter are critical for integration. That was work from Nicholas Long and Kaneva, who actually showed that implant position, meaning move it away from the buccal plate, and diameter using a smaller implant diameter, is critical for new labial plate dimension. However, these are fraught with some issues, as we'll discuss. And we all pretty much agree that internal socket grafting can help minimize ridge collapse and ultimately improve our aesthetic outcomes. The work that was originally done by Joe Kahn, who had an 8-year follow-up on cases that showed recession, those sites were not grafted. And if you speak to Joe, he'll say that he used implants that were much too wide. And that was the original thought process of the original work he had done in 2003. So we all sort of agree now that grafting can definitely help. And we're not talking short term, but we're talking long term. I know there's a very recent paper that was just published that said that internal socket grafting didn't make a difference. However, their N number was very low. It was only a 10-month follow-up, and they only looked at thick phenotype patients. So we learned this from Mike Block, that grafting is very, very important to help to maintain ridge dimension and shape, and just a variation of my partner Dennis Tarnow talking about dual zone grafting, meaning bringing it up not only where the buccal plate is, but also into the soft tissue zone, containing and protecting the graft with the temporary, allowing it to mature and heal, and hence being able to maintain ridge shape and volume, and also maximizing peri-implant soft tissue in combination with, say, platform switched implants, which again, from Hanai's work, shows that platform switching does enhance peri-implant soft tissue. Again, having greater tissue. Now, we all have skeletons in our closets, and like I said, you know, anywhere from 2 to 6 years recall, if I pulled up some of our cases that we had done, not short term, they look great short terms, but once you start looking at them long term, you'll notice here in a lot of these different cases that, you know, you have some problems occurring. We have collapse, we have tissue discoloration in those sites. And again, we want to minimize this because remediation is not a lot of fun, like I said to you before. And the question is really why. Well, the bottom line is that the blood supply to the buccal plate is really from three sources. It's the periodontal ligament, periosteum, and endosteum. The problem is that, or the reason why, a tooth that has basically a very thin buccal plate associated with it is that the tooth has the periodontal ligament. And the problem is that when we extract the tooth, that you no longer have the periodontal ligament as a source of blood supply. And the danger is that if you have only a very thin buccal plate of bone surrounding that implant, is that you only have periosteum that is nourishing that blood supply. And this is something I learned from my classmate, Kurt Pasquinelli, who's a great periodontist in San Francisco. Unfortunately, they're under lockdown as well. But I learned that from him from conversations. Now, the key then is that when you place an implant, whether it's a healed ridge or an extraction socket, you really want to have periosteum and marrow surrounding that implant, which I think gives a better opportunity to then have long-term maintenance associated with maintaining that buccal plate over time. And this has been pretty much confirmed by Spray and Danny Boozer. Danny was kind enough to send an email to Dennis and I recently, last week, just to check in how we're doing in New York. And so he's a great guy, great friend, and somebody who I've learned a lot from. And the bottom line is the following, is that if you look at Danny's 10-year recall on these cases, and the reason why he likes to do delayed is that he wants to have a thick amount of bone surrounding that implant, because at 10 years, he did show that you need to have about 2 millimeters of bone surrounding that implant to have long-term longevity. He had 6-year follow-up and 10-year follow-up on cases. And I think that is the key element. And if you ask him, he does believe that whether it's an extraction socket or healed ridge, you need to have enough thick bone over the buccal surface, preferably 2 millimeters, in order to have long-term sustainability. And it's really about biology. That's all it is. It's about having endosteum there to keep and maintain that buccal plate intact over time. But the challenge is, like I said, is the following, is that you have issues associated with stability of implants. And if you had to pick two, the two variables, length versus diameter, diameter is much more effective in giving primary stability, especially in extraction sockets, and especially in the maxilla, which is characterized by soft bone. That was work that was originally done, obviously, on the classification of bone by Ulf Leckholm and George Zarb. So we all know this very, very well. So that's really the challenge that most surgeons have to face. And again, wider implants and extraction sockets may give you better stability, but the reality is, from a standpoint of aesthetics, you really want a smaller diameter implant in order to give you better aesthetics. So again, wider implants are better for stability, but they're not as good for aesthetics, and smaller implants are great for aesthetics, but not great for stability. And hence, surgeons always have to make those choices and balance that delicately, because that's really the issue. Now, it's easy for me to criticize Petros because we don't place implants, but we certainly want to be able to have enough stability. And what they're doing in Greece and Dubai of delivering the final restoration the same day, stability becomes critical. However, you also want to have enough gap distance, as I discussed before. And if you look at this pretty well-known paper from Tom Taylor that talks about what happens with primary and secondary stability over time, is that after about 3 weeks, you could lose almost 60% of your primary stability as you have, wound healing and secondary intention, secondary stability, which really is about wound healing associated with that. So the primary stability drops down. It's really mechanical stability, and then you have integration of bone. So why wouldn't you want to have high primary stability? Some of my friends say, well, I don't need high primary stability. I can have 25 Newton centimeters. But if you do the math, that means that after 3 weeks, you only have 10 Newton centimeters holding that implant in place. And I can tell you for a fact is that all the cases that have failed are the ones that we weren't able to achieve good stability, good initial stability. So having higher stability of say 80 or higher, if you just take a number 80 and you lose 60%, you're still at 32 after 3 weeks, and that's still, acceptable. And now I understand why Costa likes high primary stability of going to 100 Newton centimeters because of this phenomenon of losing initial stability. Well, what about the papilla? That's also a key element. And I would hear lectures from Marcus Hertzler, and I heard this from Adam, our technician. They actually look pretty similar in that regard. But the bottom line is I would always hear Marcus Hertzler say this, and Adam told me this about 7 years ago. He says, well, how can you tell the implant restoration on a central incisor? And the answer is the distal papilla is always shorter or more apical, and that's the dead giveaway. If you look at then studies that were done by, say, Uli Grunder and Joe Kahn and John Coyce, they showed that what really holds the attachment or the papilla adjacent to an implant is not the implant, but actually the attachment or the supracrestal attachment on the natural tooth side. And hence, Stefano has said, well, why you would then need so much of this distance around the implant or, interproximal and buccal of at least 2 millimeters is because if you're using a non-platform switched implant, Dennis and Seng-Chun Cho and Steve Wallace showed this, is that you need about 1.5 millimeters minimum all the way around that implant because of the horizontal component of biologic width. And that's, again, why Stefano and Uli said you need at least 2 millimeters all the way around the implant. And I would agree with that. If you used a platform switched implant, you can probably cut that in half. So with platform switching, maybe it allows you to have, a little bit less dimension. But again, you still need vascularity to have viable, vital bone around the implant. And I don't think we should lose sight of that. So these, again, are some of the numbers that we're all familiar with. Again, if that distance of the implant gets too close to the adjacent tooth, usually that lateral incisor of, say, less than, say, 1 millimeter or so, then you have the risk of losing the papilla. And this is a patient, Greg, who had walked into our office looking for treatment. And again, these are some of the conditions that come about. There's also studies to say what are the risk factors, and the risk factor is that the distance between central and lateral incisor is always less than between two central incisors. So the risk is that when an implant is placed, that the distance between the central and lateral is always less, and hence the implant usually ends up closer to that lateral incisor. And again, I don't place implants, and again, the problem here is that when you're using a tapered implant, which tends to be wider by definition at the most coronal aspect of the implant. And as the implant is placed and being torqued or hand torqued into place, is that even if you're using a guide initially to give you the original osteotomy, as you're using the hand torque to torque it into place, which a lot of surgeons like that feel because surgery tends to be an art, also in a feel, is that implant winds up being a little bit too far facial, and it tends to be a little bit too far distal because the wider part hits off the palatal wall and it tends to migrate toward the distal facial. And then you end up with having an implant that's too close to the lateral, and hence you tend to lose the lateral incisor, and that's why Marcus said that. Here's an example of a patient, immediate implant. Again, the danger is that the distance between central and lateral incisor is always less. The implant tends to move and walk a little bit closer to the lateral incisor, and hence it ends up in this direction. That's not a very wide implant, it's only about 4.5 millimeters. It was an immediate extraction socket case. So again, it's the left central incisor with the pre-op, and then we had the immediate treatment, 1 week and 3-month follow-up. Now, if you look at the pre-op and the 3-month follow-up, you'll notice something very interesting. And you notice that without disconnecting the provisional restoration, that papilla is already receding. It's already receding, and we've maintained the contact. At 5 months, when I'm ready to make the final impression, you will notice here that root is now exposed because The papilla has receded. You could see the preoperative condition over here. If I then compare that to the final restoration, you could see here that yes, the papilla is shorter. I actually had to replace that veneer restoration to close off that space so you wouldn't see that root. I actually had to do that for the patient and not charge the patient for that. And if you then look at the x-ray and you then measure that distance, when you get very, very close to the adjacent tooth, you usually have marginal bone remodeling and loss of crestal bone, and hence that's why you end up with the shorter papilla. You may say, well, Steve is just being, totally neurotic about this whole concept. And, what's the big deal because that outcome doesn't look so bad? Well, here's a 6-year recall on a patient that had remediation to try to repair the papilla. And I know that Giovanni Zucchelli just published something beautiful in PRD talking about how to fix these, but these are not so easy to fix, and not everybody has the skill set of Giovanni. And the bottom line is that this is a real headache, and these are real problems that we face on a daily basis. So I don't think I'm being neurotic about this. So what's really the solution? How can we avoid, perforating the extraction socket? How can we maximize the crestal bone around our implants in order to have thick vascular bone? And how can we avoid losing the interproximal papilla? And hence the concept of changing implant designs. All implant designs, or at least I think, good implant designs have had some type of biology or biologic basis behind the design that ultimately would affect and hopefully improve our aesthetic outcomes. Like I said, everything is more about aesthetics now than survival. Again, with tapered implants, what's interesting to note is that they tend to be sort of wider at the top and more narrow at the bottom. Again, if we try to align them so that we can then have a screw retained restoration for easier maintenance of the restoration, we tend to flirt with perforating the apical part of the extraction socket, as what David Cochran had showed. Again, then, if we try to angle the implant more toward the palate to engage the triangular bone that Scott talked about, is that we then have the problem of then bringing the wider part of the implant more toward the crestal part of bone, which tends to be the thinnest. So what we've done is we've now brought the widest part of the implant to where the bone is the thinnest. And to me, that really never made any sense. Even with the coaxial implant, the coaxial implant does require drilling and angulating the implant more toward the incisal edge position, and hence you tend to have more of that wider part of the implant closer to where the crestal bone is the thinnest. And again, that never really made sense to me. So I think the bottom line is that we need to sort of turn implants upside down, where we could have the wider part of the implant where we have the greatest amount of bone, and where we have the thinnest amount of bone and the most delicate amount of bone, where we'd like to preferably have more gap distance to graft around it, a la Barry Levin's work, is that we could then shrink the diameter of the top of the implant. And let's have this, the reality is in the extraction socket, you're not using the whole implant anyhow. So why make the coronal part wider and have it a liability long-term? I just don't understand that. So hence the concept of the reverse tapered or inverted body shift concept implant, where you're sort of changing the design of the implant in a singular body form to maximize what you need. The idea really came about that I would watch my partner Dennis Tarnow. He's a big proponent. He's like Costa. He likes bigger implants for primary stability. He does believe in high primary stability, and he would like to use 5mm implants by 13 in central incisors. And on a big tooth, that's fine, but on a small tooth, it's not. So maybe a 5 or 4-5. And then the reality is that I really wanted a smaller topped implant. If he needed a 5 to a 4 at the if he needed a 5 or 4-5 at the bottom for primary stability, then I really wanted something that was smaller, like a 4 or 3-5 at the top to have gap distance. So again, it's about changing the design of the implant in a singular body form. And instead of having it wider at the top and divergent, something I learned from the guys from the Borg group in Barcelona, Javier Vela and Rodriguez, having something that's much more convergent in a singular form so that we can maximize, and then the surgeon would not have to make compromises in having the primary stability that what they would want. So reverse or inverted body shift concept, changing diameter, shape, and thread pattern and depth in regards to having it in a singular form. The bottom part is roughly 60% with a more aggressive thread design, a wider tapered shape. And then you have the coronal part, which is more narrow, cylindrical, with more shallow threads, of course, having shallower threads at the top, again, for maintenance if you lose some crestal bone and all the issues associated with peri-implantitis. Again, the best of both worlds, not sacrificing the stability that the surgeon would want, but then having the gap distance of a smaller implant at the top. It's just that simple. And the original concept, that I had come up with, really without the help of Dennis, my partner, P.O. Osman in Sweden, Costa in Greece and Dubai, and Howie Gluckman, it's really those guys who place implants that needed to really work on the design. The concept for me was like saying, well, okay, let's just shrink the top, but to make it work without these terrific people, this wouldn't happen. So I really want to thank them for doing that, because they're the ones that really had to go into the field and find out which would be the best. So this design that's from Southern Implants, that is really just a terrific design. Graham Blackbeard, the owner, and his team, and Lars Jansen and Jeremy Pittman, all these guys, it's a very clever design, because what could be done is that the apical part has the aggressive threads. It changes its thread pattern to be very shallow at the top. It's using the coaxis technology. So again, having aggressive threads where you need it most, but not at the top. I'm having a smaller pitch thread, which this paper from Mersini talks about the thread pitch or distance being more compressed. So you have more threads in contact with bone to give you the stability that you need. And if I learned anything from Craig Mish, is that you can have primary stability and good primary stability with short implants. So think of the INVERTA apical 60% as being a short implant, and Craig has a whole concept behind using short implants in order to then, get good stability and being able to have what he calls a graft-less approach, meaning graft less, because now we have better implant designs to treat our patients. Again, thread depth is important for having good stability, but this paper by Orsini shows that it's not just the thread depth that's critical, it's how close are the threads or the thread pitch or distance. So what you want to do is you want to have deep threads, but you want to compress the threads so you maximize the number of threads per unit length that's contacting bone. And that's the key in order to give good primary stability. That is really the key element associated with it. So it's not just having aggressive threads, which a lot of companies now really talk about. What about then having this sort of bone chamber concept associated with this? And again, being able to shrink the top so we have, again, a greater amount that we can graft labially, but also staying away from the adjacent natural tooth, or even multiple implants in the aesthetic zone, and having greater implant to implant distance so that we can then have more vascular bone. That's really the key. You want to have more vascular bone where you need it most. And that's really the concept behind it. I think that's the key. And like I said, in the aesthetic zone, you want to have some insurance, knowing that if you're a little bit off in placement, which again, it's very easy to do. I don't criticize the surgeons. Like I said, it's not easy to do. It's just having some insurance in case you get a little bit wayward with the placement of the implants, even using guides. And then the long-term outcomes with progressive recession around implants, the work from Daftari about craniofacial growth and development, but also maybe having inadequate bone volume around the implants, because again, we didn't have CBCTs or single cone CBCTs that we now have. And maybe some of these sites, without the work that was done with CBCTs, again from Scott Gantz in 2008, so it's only about a decade or so, is that, you know, maybe we were perforating these sites unknowingly and then compromising the blood supply to these areas and then getting recession over time. What about criticism with the design? We faced a lot of criticism with this. There's three stages to acceptance of new ideas. The first is that it's ridicule. People go, oh, that's a stupid idea. How can that fit into my, you know, concept? Or, you know, it just doesn't, you know, work for them. And that's usually the barriers that we faced originally. What we're sort of facing now is a little bit of opposition, because what happens is that when new concepts come out and people start to understand and adopt it, it threatens those that have sort of this belief that, well, they're doing cases and they're having good results, so, you know, why should I change? I mean, that's always hard to move people off of spot to get them to change. But in order to be better or to be the best you can be, you have to change and you have to adopt. So the opposition comes from sort of the fear that, well, people are starting to understand the concept and they're having, you know, good results and going against what they know and believe to be true. And then, of course, the last phase is self-evidence, where there's science to back up the concept associated with it. And we've been sort of facing this, but over time, as you'll see, there's been, you know, a good group of people. There's a global consortium of individuals using the design. The second question that people, or let me say this, the first, you know, question that we always get is, you know, how can it be removed? And I saw on Instagram that Costa said, it's really not that hard to remove. We've had some cases that have failed. They haven't integrated, and you can remove them with your fingers. It's really not hard to do. If the implant is in a poor position and it's non-restorable, there's usually probably no bone around it. And if it has suffered peri-implantitis or irreversible bone loss, where if you've, say, lost 40% of the bone around the coronal aspect of the implant, then since the coronal part is only 40%, it shouldn't be that hard to remove. It is cylindrical with shallow threads, which would allow you to then do implantoplasty. In fact, if you look at what Philippe Kayat is doing with implantoplasty, or Alan Meltzer, is that you're taking a tapered implant and you're removing the threads, and you basically take a tapered implant and you're actually converting it into an INVERTA implant when you really look at it from that perspective. So by removing the threads or making it a machine top, you should be able to maintain it because it is cylindrical, it doesn't have undercuts. And then if you determine that you want to remove it, then you can remove it, especially if it's not your implant. And it's sort of a joke, but I think we're more inclined to keeping our own implants and ready to remove other people's implants. The other question then becomes the strength. Well, you know, how about if you reduce it? You know, what about the strength? But the reality is we've only reduced the coronal part to either a standard diameter implant or a narrow diameter implant. Now, a narrow diameter implant is considered anywhere from 3 to 375. Anything below 3, there's studies to show that below 3, yes, you are, you know, potentially weakening it. But right now, we're only gone to, say, you know, a 4 or 3.5 millimeter diameter implant. So we're still within that acceptable range. You know, extra narrow would be less than 3, like I said. But if you're staying within that range of, say, standard or narrow, there are plenty of studies to show that they do just as well in that category. And of course, once you fall below 3 millimeters, you're running into potentially a higher risk of having problems with that diameter. There's been quite a few of literature that's been supporting the concepts. We work with Ron Nevins on this and a consortium of different doctors throughout the world, PO of obviously in Sweden, Barry, myself, and I. And the reality is the following. This recent paper by PO is pretty much a 2-year follow-up. I highlighted that in red. And what PO showed is that if you have enough dimension around the implant, meaning you have, say, 2 millimeters facially and interproximally, it is stable longitudinally. So that's a prospective study, and that was just published in this month's PRD with Ron Nevins. We had done, quite a bit of animal research or preclinical data to sort of look at this. And what Ron did is he found that what was very interesting to him was that roughly 3/4 of the sites where he placed implants into the foxhound model, foxhound dog with the preclinical study, histologic study, was that most of the sites he was able to get to about 100 Newton centimeters. And I know Costa would be very happy. And I think that's what was most staggering to Ron was that he was able to get it to very high insertion torque. What we purposely did not do was we did not graft around the socket. So if we had placed graft material around the implant, obviously we would be able to enhance our aesthetic outcomes, but we purposely didn't want to do that. We wanted to look at integration and would there be pressure necrosis at the apical part, being able to provide such a high amount of insertion torque. And we also wanted to look at integration without socket grafting. And you can see here is that obviously the buccal aspect, which is on the bottom side, I don't know if my pointer will be, but on the bottom side of that implant, facing more toward the bottom, is the buccal plate, which is very thin, and the palatal or the lingual side of the socket was very thick. And you'll notice here is that where the bone was thick, there was hardly any resorption. Where it was very thin, we did get resorption, but that's been well documented in many studies. But it still allowed integration by having a smaller coronal aspect of the implant. Again, out of 18 implants, we had 100% survival. There was no evidence of pressure necrosis, which is key, and Philippe Kayat showed that as well in his clinical study with Larsenebe. Bone resorption was affected by labial plate thickness, but we knew that. But having then a smaller coronal top of the implant without socket grafting did allow osseointegration, and that was really the key behind the preclinical study. Also, this concept of high insertion torque has been validated by Paolo Trisi, who showed that with higher insertion torque, you had better bone to implant contact. But this is the caveat, that provided that you're compressing soft trabecular bone was really the key. And I think that needs to be qualified. So can you provide high insertion torque? The answer is definitely yes. It just has to be trabecular or soft bone. I would not recommend if you try to compress cortical or avascular bone, if you put high insertion torque on cortical bone, you'll probably end up with pressure necrosis. So you have to really qualify the type of bone. But in the anterior maxilla, which is usually type 3 or type 4 bone, you can compress that bone all day long. We do have a global research registry, like I said, with Ron Nevins and I down in Maryland, and Tamsin Cracknell in South Africa. Barry Levin by himself. Barry's sort of my hero. He's done 90 by himself with one failure. Pretty much, again, looking at extraction sockets. And Barry has done a lot of work on looking at ISQ and the key associated with increasing ISQ, especially at the coronal aspect. ISQ talks about wobble, so Barry has done a lot of work in that respect. And if we take our data with Dennis, Guido, Valentina, and my wife Jocelyn, we've done about 96 with 2 failures. We started in 2018. We have a 98% survival. Barry has a higher survival, 99. Mostly maxillary anterior sites, which were the original concept and development was for, maxillary anterior sites. Predominantly extraction sockets, usually with type D3 or D4 bone. And because the bone quality is softer bone, we do undersize. And hopefully Costa will talk about the strategies of soft bone protocols for drilling and undersizing, because we're not going to move away from our normal strategy of drilling and an osteotomy. If you have soft bone, undersize it. The INVERTA will give you good stability, but not if you're using soft bone. No implant will give you good stability in soft bone if you improperly size that osteotomy. So in soft bone, please undersize it. So hopefully Costa will embellish that concept a little bit more. And if we do undersize it, we're able to, and at least in our data set of about 96 implants, we're able to get about 80 plus Newton centimeters of insertion torque. Let me just cover some things quickly with this. I know we got a little later start. This is just a study that was just accepted in Compendium. We do have, Compendium is publishing 4 clinical research papers, so this has been accepted for publication. What we did is we looked at 42 extraction socket implants, 21 tapered and 21 inverted body shift design. We only looked at maxillary central incisor extraction socket implants. If you look at a lot of studies, they put in, posterior sites and other sites. We looked at platform switched implants, and we had an equivalent number of biotypes per group. A second part of the paper will be just looking at the outcomes of biotypes. So I won't talk about biotypes in this study, but the bottom line is we only looked at maxillary central incisor extraction sockets, and we had, I think, a good number, over 10 in each group, 21 in each group. And we looked at insertion torque, labial bone plate dimension, tooth to implant distance, as you know, and pink aesthetic score. And could we correlate the radiographic outcomes with our clinical outcomes, meaning pink aesthetic score, collapse of the ridge, tissue discoloration, gingival recession? Again, this is the tapered implants that we looked at, conventional ones, and this is the distribution of those implants, of those 21 implants. So you could see the distribution of looking at, say, the southern coaxes, Zimmer Biomet, BioHorizons, and Dentium implants. This is the bottom line. If you look at insertion torque, the bottom line is we almost had 50 Newton centimeters higher insertion torque with the inverted body shift design implant. 36 is not a bad number, but don't forget, like I said, at 3 weeks, it drops about 60%. So you're down to about 10, which, is not the greatest amount. So having a higher insertion torque and compressing softer bone, I think is definitely an advantage. And about 70% of the sites did go between, say, 80 to 100. And like I said, in the animal study, we're able to get to about 100. Labial plate dimension. Now, this is, I think, pretty obvious. If you look at the 2 different groups, and I could sort of draw a line, it's pretty clear that by shrinking the diameter of the top of the implant, you then have the ability to have a greater amount of bone surrounding the coronal aspect of that implant. And you can see here, if I'm trying to get to Danny Boozer's 2 millimeter number or Stefano and Uli's 2 millimeter number, then you can clearly see that the tapered implant group really sort of didn't make it. And this recent paper that I mentioned to you before in PRD, their numbers barely got to, say, 1.5, and I'm not so sure that that's going to cut it long term. So having a greater amount of bone above 2 is critical. I think that's really important. Tooth to implant distance, I think this is pretty obvious. If you look at the INVERTA implant, if that was a tapered implant, you would definitely then run the risk of losing that papilla, like I said, between central and lateral incisor. And you could say here, okay, with the tapered group, well, you got to about 1.5, which is not bad. You had a millimeter greater bone or distance between the tooth and the implant in this situation over here. But this is the key. In the tapered group, we lost 25% of the papillae in that group because 25% of them were less than 1, and associated with being less than 1, we lost about 1 millimeter of crestal bone. So you have to start to think, well, in the tapered group, that's not the whole story. The whole story in the tapered group is that 1 out of 4 patients lost the papilla, and that becomes a problem. And what about pink aesthetic score? Well, Cozen and Hugo de Brun showed that if you're between 8 and 12, that's average. And if you're above 12, you're above average. Now, I don't know of any dentist who considers themselves average. And the bottom line here is that we were able to get much more consistent outcomes or clinical outcomes because we had better radiographic data to validate the clinical outcomes. And hence, again, we had much better aesthetic results. In fact, in the tapered group, roughly 2/3 were considered average, whereas only 14% in the inverted body shift category were considered average. So we had 85%, or the majority of the implants in the inverted body shift group, being above average. And I think that's a key element in this whole discussion. So as a conclusion is the following. We did statistics to actually look at the differences associated with it. So all the groups had statistically significant difference. We also found that with tapered implants, there was a higher frequency of recession, tissue discoloration, and collapse, which I think is one of the key elements. And again, not going into the biotypes, but the inverted body shift implant really was not really affected by biotype, because obviously you're gaining more bone and tissue around those implants. Let me just talk about some clinical applications before I finish up. It was really designed for extraction sockets, but you can use it for edentulous sites. I have some of my friends who are using it for edentulous sites as well. So you could really use it for both. And what we have found is that we're probably using the 4-5-3-5 combination implant combination most of the time. That implant, if you had to ask me what one implant you should purchase if you wanted to use this design and not have a huge inventory, just use the 4-5-3-5. I think that, to me, would be the workhorse in those situations. Obviously, second bi to second bi in the top, using the coaxial design is very good for that because of the anatomy, and lower canine to second bicuspid in the lower. That's really the sites that you would probably want to utilize this implant, which is, quite a number of sites that you would have to deal with. Let me just show you two examples, and then I'll hand it off to Costa.